Welcome to this webcast. I'm going to cover a very brief review of shock. This is Dr. Sullivan. If you have any questions, let me know. And I just wanted to remind you that a lot of the resources that I used, I just went into up-to-date, typed in shock, and I've included a couple of these in here as a PDF. But of course, probably the best way is just to go straight to up-to-date, and that way you have the links and things. These are the learning objectives that we'll cover. And again, this is straight out of one of the readings, and I just wanted to point out that I'm going to cover shock and some of the causes of shock, and we'll focus, since this is going to be the trauma scheme, on hypovolemic shock, and the clinical presentation for shock is often hypotension, and so that, remember, is a scheme you covered in year one. You also have low urine output, changes in mental status, changes sometimes in the skin being cool and clammy, not always. You can have metabolic acidosis. So these are some of the cardinal signs of shock, and we're going to cover some mechanisms. So part of trauma is going to be blood loss, and blood loss can cause shock. And so we'll differentiate hypovolemic shock from the other forms of shock, which you might remember, but this will be the focus. And so I threw in the hypotension scheme, the shock scheme that you might remember from year one, where you basically have a balance of cardiac output and total peripheral resistance or systemic vascular resistance, which then help determine your blood pressure. And when any of these are compromised, you have then a reduction in blood pressure, which can lead to shock. Low perfusion to your organs. And causes of the decreased cardiac output can be hypovolemic shock. Again, that trauma fits in nicely there. You can also have problems with the heart. You can have heart attack, or anytime the heart's not pumping well, that can lead to hypotension as well. And that's so cardiogenic is a form of shock. And then on the other side here, you have this decrease in systemic vascular resistance, or decrease in TPR. That's basically when you have widespread vasodilation, and that can happen in sepsis, drugs, neurogenic causes. So, and we'll review a little bit of all of this. If you don't want to rely on up-to-date, there's some other good resources out there as well. Okay, so the first one was to distinguish between the various forms of shock. And again, I said I'm going to focus a little more on hypovolemic shock since it's related most directly to trauma. But just all forms of shock, if you think about it, you've got a severe reduction in tissue perfusion. Again, this is usually because and due to this hypotension. So again, if your blood pressure is compromised, your tissue perfusion is compromised, that can lead to ischemia, hypoxia, local cell death. Eventually, if there's enough cell death, that can lead to organ failure. And so if you go to most of your resources, including up-to-date, they'll usually have shock broken down into three types or three categories: cardiogenic shock, hypovolemic shock, and distributive shock. Some sources like Porth here have this fourth category, obstructive, but most will just throw that into cardiogenic. So that's a little easier to just think of three. So again, distributive shock is when you have this total loss of vascular tone, which then compromises your perfusion and blood pressure to the whole body. And septic shock, anaphylactic shock, drugs that could cause widespread vasodilation could fit into distributive shock. That's going to be a decrease in TPR, or what some people like to call systemic vascular resistance. Cardiogenic shock would have these obstructive forms, so something like a pneumothorax, or obstruction to outflow in the heart, aorta, pulmonary trunk. Those would sort of fit in cardiogenic, which would include myocardial infarction, arrhythmias that simply don't allow for adequate pumping, defects in the heart, cardiac surgery. So cardiogenic shock is when the pump's failing. And then where I think trauma fits in best, and which form of shock that would fit in with best, is hypovolemic shock. So hypovolemic shock is hemorrhagic shock, so basically loss of blood, hypovolemia, loss of plasma, which that could be due to dehydration or diarrhea or vomiting, and sort of related to loss of extracellular fluid. So that's what we'll focus on. Describe the consequences of low blood flow to cells and tissues. So hopefully it's kind of obvious that if you have limited blood flow to your organs or tissues, you're going to decrease the oxygen supply. You're going to throw into the tissue into pH unbalance, maybe the CO2 retention and lactic acid, that sort of stuff will affect the pH. Low O2 will affect the amount of ATP. So if we don't have ATP for our cells, basically the little things that cells like to do, like pump ions around and regulate pH, will become deranged, and eventually the cells will swell. The cells can die. They can undergo apoptosis. And so if you think about it, if you basically leading to that lack of perfusion leads to all these things where you start to accumulate sodium and calcium. That can cause cell swelling. The calcium can cause problems with the mitochondria, can trigger apoptosis and cell necrosis. pH imbalance, again, because of the CO2 and the lack of blood supply. Could leave lactic acid around and things like that. Both of those can contribute to decreased pH. Inflammatory responses, and again, just overall cell dysfunction. Again, if there's enough cell dysfunction, cell necrosis, apoptosis, that can lead to organ failure and organ dysfunction. So basically, shock is a circulatory collapse, which then, our cells just aren't supported and can't survive. Right, that's from Up to Date. You can read that. Okay, so predict the factors that would cause MAP to decrease in situations of shock. So again, the whole thing in circulatory collapse or shock is that you've compromised your mean arterial pressure. Mean arterial pressure is due to your cardiac output and your total peripheral resistance. Again, a lot of textbooks like to call that systemic vascular resistance, so don't get confused by that. So if we think about cardiac output, we're thinking about heart rate. We're thinking about stroke volume, right? So how fast the heart's pumping and how much the heart is pumping. And then total peripheral resistance is typically due mostly to your arterioles and their tone. So are they vasoconstricted or are they vasodilated? If we kind of step back bigger picture and start thinking about what's going to affect our stroke volume, well, that's going to also involve our blood volume. Right, so if you've lost your blood volume, because we're talking about, say, hemorrhagic shock or hypovolemic shock, you lose your blood volume, you compromise your stroke volume, your cardiac output is reduced, and that would cause your mean arterial pressure to be reduced. If we step back and look at other causes, we might say something like, well, what if your patient's in septic shock? That might cause widespread vasodilation of your arterioles. That causes your total peripheral resistance to go way, way down. Your cardiac output might actually try to go up to compensate, but still you may have a reduction in blood pressure. So if we think about the different forms of shock, and again, if we just think cardiogenic shock, that's going to affect the pump, which is going to then compromise our cardiac output and lower our blood pressure. If we think of distributive shock, you can think of dilating your arterioles. The blood then is distributed throughout the body without proper regulation, and that drops your blood pressure. Also, in distributive shock, you can also think of the veins as losing their tone. If you lose the venous tone, then you're going to have blood pooling in the veins, not returning to the heart. That's going to further decrease your blood pressure because, remember, the heart can't pump what it can't get back to it. So that would be distributive shock. If we think of hypovolemic shock, we've simply lost our blood volume. Either we've lost blood through leaking out of the capillaries, maybe in sort of sweating, or we've had maybe an arterial cut and severe blood loss, and so that's going to compromise the amount of blood, which is going to limit the amount of blood pressure we'll have. All right, so remember, blood pressure is dependent on the actions of the heart and venous return, and also TPR, which is dependent more on our arterioles, and those two factors help determine our blood pressure. And if we come back to these, hopefully you can see sort of the relationship of how those would affect mean arterial pressure. And so again, cardiogenic, hypovolemic, distributive will all decrease blood pressure just through slightly different mechanisms here, compromising venous return, but also compromising total peripheral resistance is probably the main thing, is that becomes so low that our blood pressure is reduced. In cardiogenic shock, our cardiac output is reduced because the heart's not pumping well. In hypovolemia, same thing, our cardiac output is reduced because we simply don't have the blood to circulate around. So these are probably the main things going on. Okay, and there's a good, I'm not sure what textbook I found this from, but they sort of broke it down by the different types of shock, what's it affecting, again, your cardiac output, things on this side of things, and total peripheral resistance on this side. Can you think of some causes of hypovolemic shock? Again, I'm sort of focusing on that because it seemed most closely related to trauma. Hypovolemic shock is, of course, caused by shark attacks. And so the shark bites this person bleeds, all their blood. And also I know from year one, we talked a lot about the hockey player who got his common carotid slit. Of course, those would both cause hypovolemic shock. Probably more common causes are going to be trauma, ectopic pregnancy, maybe an aortic aneurysm, gastric bleeding, burns, dehydration, diarrhea. Again, those aren't as obvious. Those aren't the loss of blood per se, but more loss of the extracellular fluid and the plasma. But again, same effect. Okay, explain the compensatory mechanisms that are triggered to maintain mean arterial pressure. So again, we're going to use our example of hypovolemic shock, say due to trauma. And I want you to think about what are going to be the cardiovascular changes and adaptations to help preserve our mean arterial pressure, which again, the whole problem with shock is that our mean arterial pressure has been compromised. And then also we're going to throw in the renal changes as well. So let's look at the example we've seen in class before. If you want to go remind yourself, you can go watch YouTube. Hockey player got his carotid artery severed and he bled out a lot. And I think I remember somewhere saying he lost like 40-50% of his blood volume. Long time ago there was another hockey injury. Both these guys survived. This guy got his jugular cut by a skate as well. So we got our hockey player. Loses a lot of blood, a significant amount of blood, so much so that it compromises blood pressure. And so we want to bring that blood pressure maybe not back to normal, but we certainly want to, our goal would be to approach normal, the body, as far as homeostatic mechanism. So we're going to try to bring it up as high as possible. So again, if you think about this here, we've got mean arterial pressure. It's gone down because we've lost some of our blood volume. So we should be able to predict what are we going to do to help increase cardiac output, and what are we going to do to help increase total peripheral resistance in order to maybe not bring mean arterial back up to normal, but at least try to normalize it or preserve it. So there's going to be a quick response, and then there'll be a more slow response, which we'll talk about. That'll be more the renal system will be a little slower. So let's focus on the fast response. So again, when you lose a lot of blood, what are going to be the compensatory responses? Well, one of the things is your baroreceptors in your large arteries, they're going to reduce their firing pattern. We're going to reduce the firing of action potentials back to the medulla. When the medulla gets those reduced signals, the medulla then responds by increasing sympathetic output, basically throughout the body. All right, so sympathetic tone or sympathetic output is probably a better word to use. So again, sympathetic output, neurons, you should think norepinephrine, maybe activation of the medulla and epinephrine, norepinephrine. So in terms of cardiac output, we're going to increase our heart rate, right? Extremely high, hopefully, to help pump more blood. We could also try to increase stroke volume, at least try. The stroke volume might be compromised simply because we lost so much blood, but we can increase contractility of the heart, little myocytes. Again, these mechanisms will be norepinephrine, beta-1, adrenergic signaling. If we then, so that's kind of the heart's response. What about the arterioles? We can adjust the arterioles, and we want to increase TPR. or SVR, whatever you like to use. We want to increase, basically vasoconstrict our arterioles. Obviously not maybe to our brain and our heart, but certainly to our skin, our digestive tract, maybe our non-working muscles. And we're going to cause vasoconstriction. Again, that'll be through norepinephrine, in this case alpha-1 adrenergic signaling. And then the other thing is to think about the veins. Because the veins hold so much blood volume, by just changing the venous tone a little bit, by decreasing venous compliance and increasing venoconstriction, we're going to actually help try to increase venous return to the heart of what little blood we have. Increase that venous return to the heart by increasing venous tone, or we could write that decrease venous compliance. Basically have the veins hold less blood, and so that blood then is shifted back to the heart and the arterial side. Again, this all is this as well is done through norepinephrine, alpha-1 adrenergic signaling of the smooth muscle cells of our veins. Right, so again, big picture, remember, arterioles affect total peripheral resistance or systemic vascular resistance. By constricting them, we're going to help increase our TPR, which is going to help preserve or bring up our MAP. On the other side of things, if you think about the veins, really the veins are just, I like to simplify it and think of the veins as just venous return. So when you constrict the veins, you help get that blood volume back to the heart, and so in that case you're increasing or you're helping preserve the cardiac output side of things by helping venous return, which helps improve stroke volume, which helps cardiac output go up, and then hopefully increase mean arterial pressure. All right, and again, the mechanisms to remind you are those alpha-1 adrenergic receptors on our smooth muscle cells in our veins and our arterioles, and norepinephrine released from sympathetic nerves innervating those. And again, will we totally compensate? It probably depends on the amount of blood loss, but we certainly want to try to come up as high as possible. Okay, what about the longer term response? This is going to involve more of the renal system and the renin-angiotensin-aldosterone system. And so hopefully you remember angiotensinogen made by the liver can be converted to angiotensin 1 by renin. Renin is made and released by the little kidney cells. And one of the things that stimulates that is decreased mean arterial pressure or increased sympathetic activation. So the two of those things are going on. So we're going to have increased renin levels. That's going to increase our angiotensin 1. Angiotensin 1 can be converted to this active hormone signaler Ang2 by the enzyme ACE. The enzyme ACE is located in the lungs and kidneys and kind of throughout the vascular endothelium. So we've got a lot of Ang2. You might remember Ang2 does a lot of things. Ang2 is a potent vasoconstrictor. So it's going to help to cause vasoconstriction, which will help increase our total peripheral resistance. You also might remember that Ang2 can stimulate aldosterone secretion from the adrenal gland. So we can draw the little adrenal gland up here. And aldosterone is then going to affect sodium and water retention and help increase our blood volume. And again, so that takes a little more time, but that increased blood volume is going to help basically contribute to your blood pressure as well. And so in case we forgot anything there, I threw in the slide that I drew last year. And so the thing to remember about Ang2 has a lot of effects. It can go up to the hypothalamus and create thirst. It can also cause some ADH secretion. Ang2 can also go to the adrenal cortex and cause aldosterone secretion. Aldosterone is going to go to the kidneys and help increase sodium and water reabsorption. That's going to help improve our cardiac output through blood volume. Ang2 can also go to systemic arterioles and cause vasoconstriction. Oops. And that can help increase our TPR. Okay. And and I threw that in there. So there I have thirst and fluid intake. Ang2 can do that. Ang2 can increase aldosterone. Ang2 can vasoconstrict those systemic arterioles. I just threw this in there for your information. So if you want to think, how much blood volume can you lose before you really start compromising your mean arterial pressure? And it turns out you can lose quite a bit, but then eventually cardiac output starts to get compromised and your blood pressure with it. Okay, so I just threw in some slides here again that integrate the responses to preserve MAP. So the integrating comes from the cardiovascular system, the heart and blood vessels, and then of course our kidney, sort of putting those all together. If we think of the cardiovascular system as the fast response and the kidney as a little bit of the slow response, again, if you think about it, it doesn't have to be blood loss due to trauma. It could also be dehydration or diarrhea or something that's causing your extracellular fluid volume loss. But again, the fast response, if you break that down, we're going to constrict arterioles, constrict veins, affecting our TPR versus our venous return, increase heart rate to increase cardiac output. We're going to increase contractility to help maximize stroke volume. On the slow side of things, again, involving the renin, angiotensin, aldosterone system, we're going to get Ang2 levels elevated, which are going to have pretty profound effects. We can also stimulate ADH, again, through just stress and things like that. We're also going to get aldosterone increase through Ang2. Aldosterone and ADH will help increase water and sodium levels and decrease urine output. Again, that's going to help maintain our blood volume and affect our stroke volume and cardiac output. Again, all the goal here is to improve MAP. This is from one of the board review books, and I just like the way they put this in here. So it's I modified it a little bit, but it just has some of the mechanisms we just mentioned. And this is a slide again. I just threw these in there if you want to review. Don't feel like you have to memorize these, but just sort of, I used these before in some of the blood pressure year 1 stuff, so I put them in here for your reference. Same thing here. I wanted just to throw the slide in there as a review. Since we've learned of so many endogenous regulators of vascular tone, I wanted to throw them all on a slide so you can see them. Again, endogenous are things that our body makes. And so we have everything like norepi and epinephrine, which combine alpha-1 adrenergic receptors. That obviously causes veno and arteriolar constriction. Nitric oxide, for the most part, causes vasodilation of both arteries and arterioles and veins. Endothelin-1, thromboxane A2, both of those, I believe, vasoconstrictors. Ang2 is a potent vasoconstrictor. ADH, also known as vasopressin, is obviously a vasoconstrictor. Norepinephrine and epinephrine, when they bind to beta-2 adrenergic receptors, they actually then act in vasodilation. That's usually limited to certain vascular beds like the heart and skeletal muscle. So that's not very widespread. Prostacyclin is I believe, a vasodilator as well, produced by endothelial cells. Adenosine, for the most part, acts through sort of metabolic vasodilation. So just a review, throw that in there. As far as what we're talking about, shock states, one thing, the thing to think about, of course, is the body's going to use norepinephrine as one of those primary vasoconstrictors to increase TPR and increase venous tone. But also Ang2 and ADH are going to try to increase TPR as well, because those are produced in high amounts when you have that sort of trauma and hemorrhagic, or I keep saying hemorrhagic, but I mean hypovolemic shock. The other thing, though, to think about, if you look at this diagram here, is, for example, septic and anaphylactic shock may increase things like nitric oxide or histamine, and that can certainly cause actually widespread vasodilation. So I know NO is often mentioned in causing sometimes widespread vasodilation. So if you think about those conditions that are decreasing TPR and then compromising blood pressure and causing shock, sometimes that can be due to some of these other mediators. All right, real quick, and again, I would encourage you to check out Up to Date. Had a nice article on how do you treat shock, and shock related to trauma. And the main thing that we've been talking about here would really just be to stop the blood loss as far as hypovolemic shock, and of course intravenous fluid resuscitation, so either plasma or blood to correct the loss of blood. And just one of the things I wanted to mention is that shock and trauma lead to situations of coagulopathy. So basically, there's been this observation that, hey, when people have trauma and shock, they have this inability to clot. Obviously, that could be a problem, right? It's associated with increased risk of mortality and organ failure if you're not able to clot. The mechanisms of it are just about as diverse as the causes of shock. Sometimes it's due to the low blood flow is known to cause what people refer to as acute traumatic coagulopathy. There's also disseminated intravascular coagulation, which would be a coagulopathy where you've used up all your clotting factor. There's also, if you add a lot of fluid to the body, there's this dilutional coagulopathy. There's hypothermia and acidosis, which seem to impair clotting. So a whole diverse set of mechanisms can lead to this inability to clot in shock and trauma. So I just wanted to remind you guys about that. And then finally, I put in some slides here that I did an autonomic nervous system review for the 2016 students. And so I just threw it in here while you're studying in case you get overwhelmed like a lot of us do about, trying to remember all the different adrenergic, cholinergic signaling. And so most of you probably already know this stuff, but I just put these in there in case you want just an easy review as you're studying. All right, and I think that is all I have. So if you have any questions about these, I know I went through them pretty quick. I really wanted you guys to focus more on the reading. I included a couple articles and just sort of a chance to review shock and a little bit about regulation of mean arterial pressure. All right, see ya.